land acknowledgement that's always done for grand rounds. So Ottawa is built on the unceded Algonquin and Nauvoo territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. And CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So with that, we'll launch our grand rounds, welcoming Olivier Cusson to present today. You can see his topic here today. So PICU Vascular Access Expansion Project and Building a Curriculum. And Olivier completed his Royal College certification for pediatric critical care in 2023. And he's currently a CHEO fellow and is pursuing a master's in medical education at U Ottawa. Over the last year, he has centered his interests and efforts in developing a specialized vascular access curriculum for the PICU fellows at CHEO, and is also developing an expertise in point-of-care ultrasound. He's working currently a mixture of clinical assistantships, MRP for the SPOT team and IMCU at CHEO, as well as locums in other centers. So thanks, Olivier, and thanks for presenting, and look forward to hearing about the curriculum and how it's going.
Thank you so much, Pranish. Thank you for the introduction. I really much appreciate it. And I'm very excited and happy to share my journey with you guys over the past year around specialized vascular access. Briefly, before we get to our objectives shortly, I want to start by thanking the Department of Pediatrics for enabling this project via the CHEO Fellowship. Without that funding and that opportunity, I wouldn't have had all the time to spend really refining and working on this project. And of course, I want to thank the Vascular Access team for their role that is going to be highlighted throughout this presentation. Again, without them, this project would not have been the same. The objectives for today's presentation are as follows. First, we will define and describe specialized pediatric vascular access. We will then highlight the success of the vascular access team at CHEO. And then we will describe how we created a specialized vascular access curriculum for PICU fellows. I want to emphasize right here that this presentation and this curriculum was not about changing a system in place that already works well. The vascular access team at CHEO is great and they provide a great service. This program was really about building a skill set that will be beneficial for ICUs all across Canada. And so at first, during this project, we wondered how we could create a vascular access program when we already have a very strong specialized vascular access team. I'm very happy with the work that we have done over the past year, and an example of that can be highlighted through a recent patient in MDU for whom IV access was very difficult, even for VAT. And the patient was going to go back home without therapy, actually, because we couldn't secure access. And at this point, the vascular access team reached out to one of my trainees to try for vascular access, who was successful. And I really like this story because it emphasizes interdepartmental relations and really work between different parts of the hospital. And it's with that kind of energy and passion for vascular access that's really fueled the curriculum over the past year. A couple of months ago, our first graduate finished training and was extremely proud to receive a certificate. To be completely honest with the people here today, I didn't think the certificates would catch on, but you can ask people from PICU. At this time, certificates are highly sought for. When I asked Dare if he was comfortable with me sharing this picture of him and saying it was one of his greatest accomplishments over the past 10 years, his answer was, well, you know, Ollie, it's very possible that I said that because my kids are over 10 years old. And so that just shows how much he cared for the program. There's going to be a couple of abbreviations that will be used fairly frequently through the presentation, and I wanted to highlight them here. PIV is a peripheral intravenous line or peripheral intravenous catheter. A PIC is a peripherally inserted central venous catheter. US is ultrasound, and VAT is CHEO's vascular access team. Let's begin by better defining what I mean by specialized vascular access in pediatric and skimming over some of the literature on the topic. Throughout this presentation, specialized vascular access will be defined as ultrasound-guided PIVs extended dwell catheters, and PICC lines. Pediatric vascular access in general is challenging for many reasons, and I'm sure any pediatricians here would agree. Patients have small vessels, they can move around quite a bit, and will show more signs of distress than an adult patient. And that is even more true in acute care settings, where hemodynamic status, intravascular status, or acidosis can further impede potential vascular access. And that leads, difficult access is linked with risk of delaying initiation of therapies. And so a key feature of multiple acute disease processes in pediatrics is the importance of time to therapy. If the patient does not have reliable vascular access, it can delay initiation of life-saving therapies. If we take septic shock as a simple example, the Surviving Sepsis 2020 guidelines recommend that patients presenting in septic shock start empiric antimicrobial therapy as soon as possible, and ideally within 1 hour of recognition. And so delay of initiation of therapy is actually associated with longer hospital stay and higher mortality. I'm of course not saying that specialized vascular access should replace other forms of vascular access, notably intraosseous insertion. IOs are still have very much their place in acute care. But what I am saying is pediatric vascular access can be challenging, and not having an IV or not having a type of access can be life-threatening. And specialized vascular access can address some, not all of these issues, depending on the context. Bringing the discussion back to really more of a PICU setting, in critical care, we are reliant on vascular access for the administration of a lot of therapies. We can think about sedatives for patients who are dependent on mechanical ventilation, TPN, vasoactive medications. And for us, having inadequate access can mean that we have to stop continuous infusions to administer some PRN medications, and that can lead to patient discomfort or even impede endotracheal tube safety. And also, in PICU, we order a significant amount of blood work, which of course we have to be mindful and order the least possible, but even the minimum amount of blood work required is still quite a bit. And so every time we're able to have an IV that gives us blood return, it means one less spoke for a patient, less discomfort for the patient and their family. And that's something that's very important, because it goes without saying that the main victims of difficult vascular access and multiple attempts at IVs are the patients and their families. And so in this qualitative study conducted through multiple interviews, both parents and patients describe vascular access as one of the worst part of their hospital stay. There's frustration with inexperienced personnel attempting vascular access, and that the flip side of that is that a trained, specialized vascular access resource like our VAT team is associated with lower anxiety and more satisfaction at the bedside. So as we were building this curriculum, we needed to be very mindful that through our journey between exposing physicians to specialized vascular access, we would want to eventually get to a point where we can provide lower anxiety and satisfaction at the bedside through less attempts. But through that process, we had to be mindful not to cause unnecessary patient harm. At CHEO, we have a very clear vascular access policy that, through a stepwise approach, allow for allocation of resources for timely insertion of vascular access device. And so this is one of the main algorithms that I'll quickly walk people over. When a patient needs an IV, the first thing we should think about is pain management. A good way to help with that is to involve our child life services, who do an amazing job at distraction and helping during painful procedures. If a patient has a difficult vascular access or has had multiple attempts or needs an IV for a prolonged period, the VAT team should be consulted to help with the IV start. If the VAT team is not available, or that we are off hours, or that VAT team has a difficulty with the access, then PICU are usually the first ones to be consulted, although NICU and the transport team are also obviously to be considered. And so I want to highlight here that not all centers are so lucky in terms of existence of such a policy and the availability of a specialized vascular access team. Other centers do not have access to those resources. And as such, the Royal College states that fellows are expected to develop ultrasound-guided vascular access skills that are not limited to central venous lines. Moreover, there's a growing expectation from other centers that PICU fellows finish training with some specialized vascular access expertise. And so, as stated earlier, specialized vascular access is here defined in this presentation as ultrasound-guided PIVs, extended well, and PICs. And I wonder if people want to take a little moment to reflect on how they would define each of these devices and how they would differentiate them. And so, ultrasound-guided PIVs are regular catheters inserted with ultrasound guidance. I'll be going over that technique more on the next few slides. Extended wall catheters are longer catheters. In pediatrics here at CHEO, we usually use 4 to 8 centimeters, but in the adults, they can be as long as 20 centimeters. A key feature is that they're not central line. They do not cross any articulation, but they have their own sets of advantages that we'll talk over as well. And PICC lines are central lines that can stay in place for weeks to sometimes months, and can provide reliable long-term access, and can also have multiple lumens. Ultrasound-guided peripheral access has seen its use greatly increase over the past few years and decades with the development of high-resolution ultrasound machines with frame rates that facilitates tracking of the needle. Ultrasound-guided access is associated with increased first attempt success rate and increased catheter longevity. The thought of why IVs last longer when they're inserted with ultrasound is because you see the vessel, you can better predict when you are going to hit the vessel with your needle. And as such, there is likely more catheter inside the vessel, whereas with usual landmarking and palpation techniques, you may hit the vessel at really the end of your catheter and only have a couple of millimeters inside the vessel. And the thought is that these IVs probably do not last as long as an IV with more catheter inside the vessel. With ultrasound-guided vascular access, time to therapy is also improved. And there are 2 main ways that ultrasound can help one insert vascular access. So there's the dynamic needle positioning approach and the static approach. Briefly, a static approach means that the ultrasound probe is held at a single view, and then you see the vessel, you see how deep it is, and you can try to hit it either exactly on your view or use ultrasound in an informed way to know where the vessel is. Dynamic needle positioning, we'll go over the next few slides, but is a superior approach and allows for continuous tracking of the needle all the way through. I'll have a video next slide to show really the procedure itself, but briefly what you're going to see is our learner is going to do an attempt, identify where the needle tip is on the ultrasound screen, which is going to be a bright white spot, and then find where that tip of the needle is. So that is where the bright spot is going to disappear. And then in a series of multiple small movements, advance until he is in the vessel and keep going a little bit before cannulating. Unfortunately, the video's frame rate and because of latency issues is going to be pretty slow. So what I'll do is I'll pause it a couple of times and then I'll let it play, but I'm sorry, it may not be super fluid, that video. So you can see our learner here start his attempt. And right here, you can see my finger kind of pointing at the bright spot. And so this is where the needle is. And so as you'll see the learner scan more forward, we will lose that needle tip. Right here, so he's scanned further along, we've lost the needle tip. He will advance his needle back to the center of the vessel. And then through a series of 5 to 10 of these movements, he will keep going inside the vessel. Now, in this case, the vessel is pretty big, and you could tell me, well, Ollie, why didn't he cannulate right away when he was in the vessel? So 2 things there. One, the fact that you keep going while you're still in the vessel makes cannulation easier. And also when a vessel is not that big and not that shallow, you will see your needle be subcutaneous, and then you'll be able to advance it in a series of small movements. And so you can see here, hopefully, despite the video being a bit slow, that he does a couple of movements before inserting the catheter and flushing it. The goal here is not to go over the whole technique of ultrasound-guided vascular access, but really the highlighting dynamic needle positioning as a strategy to improve and insert IVs. Now let's talk about extended dwell catheters. These are in many ways superior to PIVs. One of the main advantages is longevity of these catheters. So they last quite a while longer. We are talking about days to weeks, whereas regular PIVs last 3 to 4 days. And they're also safer than PIVs for some of the vesicant medication that we can administer. Some antibiotics, vasoactives at low concentrations are safer when administered through extended dwells when compared to PIVs. The caveat here is that data around extended dwell catheters is almost exclusively from adult literature. And so there's opportunity for academic work around pediatric extended dwell catheters. The thought is that these catheters, the insertion can be a bit more longer and more painful. And so we usually use topical analgesia and or mild sedation when we insert them. But again, there's no clear pediatric data on the topic. At this time, I'd like to give the opportunity for Sandra, one of the VAT team's most expert member, to talk about their program and their success at CHEO. I wonder if, Sandra, you were able to join the conversation. Yes, I see you here.
Yes, I did have some technical difficulties, but Alisa was shared his computer with me, so that's good.
Okay. And briefly, I'll just introduce you, Sandra, for the people who don't know you. Sandra is one of the most expert members of the VAT team. If I had one attempt to give someone and I really needed an IV for someone, she would be the person I would trust the most to get that IV. Her expertise is unmatched. And I'm very happy. Thank you so much, Sandra, for being able to join. And I'll let you talk a bit about the VAT team, and I'll go through the slides as you go along. Thank you.
Sounds good. Thank you so much, Ollie. So VAT, we have 8 members at this point. I don't think it's gonna be any more than that. So we are working 7:30 to 11 during the weekdays, and on weekends we are here from 7:30 to 7:30, so 12-hour days. We do help with we do all starts on inpatient units, but we do help a lot with the PICU, Emerge, MDU, dialysis, NICU. So we do help if there is a need. Also phlebotomy. We do have phlebotomy during the days on inpatient units, but we help a lot there. I'm not sure where you find those pictures because I didn't have any, but yeah, there's some pictures of our cart and few of my members, and with ultrasound and cart, it's always a really big challenge to get everything rolled together. So it's very important. We did a lots of work for the best practice guidelines and BPSO at CHEO for IVs. We developed the TLC poster, so it's touch, look, and compare. So we have less incidents of interstitial IVs. We also developed algorithm that Ollie also talked about. And about line maintenance, we did a lots of collapses for central lines, for PIVs, to minimize complication of the IV infiltration and to help nurses navigate that. So there's just a graph of how many IVs and PICC lines and those rather some dressing changes that we do for central lines. As you see, it's climbing. We had in 2017 149 PICC lines, and now we are up to, I think, let me just see, over 200, 261. So it is getting more, which is great. We do like to see timely management. If kids need a PICC, it's better to get it done as soon as possible than after the multiple pokes. So it's just a key message for me. It's really to follow the algorithm because we had a lot, it is getting better, but we had lots of issues with the 10, 15 attempts for IV, which is not good for anybody. And we really want to prevent those veins. So least amount of IVs that you can guys work with, it's always the best. Also minimize the vena punctures for blood work, group the blood work. Lots of times we come and, there's order for lights, and an hour later they want a CBC, and then, so we had like multiple. So I would like, if as much as possible, if you guys can, just group it together, all blood work that you need for the day for the patient, so they don't have to be poked multiple times. And also, if you know that IV is gonna need 5, 7, 10 days, maybe let us know early so we can either put extended well or PICC line, depending of the need and depending of the medication that patient is getting. Also, I just want to go back to one slide that you have that for the blood draws. We do, like, if patient does need a blood draw, like it's your slide that you went over, I just happened to see. We do not encourage doing blood works from the running IVs. If it's not best practice guidelines, if patient does need multiple IVs, then saline lock, it's a good option to have, but we do not encourage you doing blood work from the running IVs for, yeah.
Yeah, as much as we can avoid, for sure.
Exactly, yeah.
Thank you.
So that's it, and I'm glad that to be part of education in PICU for you guys. It is a great that you're doing.
Thank you so much. Thank you so much, Sandra, for joining us and talking a bit about your program and the help you've brought us is, again, so important. And if I may just briefly go back to the statistics slide, just to highlight for everyone here, 3,000 PIVs last year. That means that every single day at CHEO, between 8 or 9 PIVs are inserted by someone from the VAT team every single day, all year round. And that means that each of the 8 members on the VAT team does around 400 IVs per year. So just to give those numbers into perspective and to show how much expertise these guys have. Let's move on to really the curriculum that we've built over the past year. This idea first arose from 2 main elements. First of all, within the CHEO vascular access algorithm, every once in a while, PICU may hear about a patient needing vascular access, especially during times where, unfortunately, there is no VAT coverage or patients have difficult IV access. So it was important for us to enable PICU to have the best vascular access skills possible. And second of all, which is even more important reason, CHEO's Pediatric Critical Care Program has trained over the years physicians who are working all over Canada. You have here a map of the 19 PICUs in Canada, and every yellow circle is a center where at least one physician that was trained at CHEO in critical care is currently working. So I'm highlighting here that most centers have people from CHEO working, and some of these centers, for example, Halifax, have 3 physicians from CHEO. There's 2 in Hamilton. Here in Ottawa, we have quite a few physicians as well, obviously. And so not all of these centers that have a yellow circle have a vascular access team that is as great as Sandra's team or a vascular access team at all. And so it was important for us to enable our fellows to develop the required vascular access training because in these centers, the algorithm might be that when there is a difficult IV, PICU is consulted sooner rather than later, and we wanted to give our physicians the best training possible. And so in building this curriculum, the theoretical framework was taken from Kern's 6 steps to curriculum development. My goal here is not to go over all the educational theory in details, but give you guys an idea. And so Kern's 6 steps are first, problem identification and general needs assessment, followed by a targeted needs assessment, establishment of specific goals and learning outcomes, then educational strategies to reach these learning outcomes, implementation, usually through a pilot phase or like a early phase of the project, and then evaluation and feedback of the curriculum. The last thing I'll say about this specific approach is, although it's presenting in a sequential order, all of these steps are kind of intertwined and everything's going on a bit at once, and that's normal. That's part of the realist curriculum building in a hospital or in any facility. In the early stages of this project, multiple stakeholders were involved that are listed in the presentation. It was important to take the time to discuss how this curriculum was going to be implemented, how to ensure success, and how to build something sustainable and attainable without causing increased patient harm. And so there were multiple meetings and discussions. For example, in the early iterations of this curriculum, it was decided not to pursue PICC line insertion training for learners. And so similar to the VAT team's training process, where nursing first learn about ultrasound-guided IVs, extended dwells, and then PICC lines, we wanted to first train our physicians for ultrasound-guided IVs, extended dwells, before moving on to PICC lines. A targeted needs assessment was conducted, and it was a survey amongst PICU staff and fellows, and showed 3 main findings. So for specialized vascular access specifically, there was lack of experience, but there was also a great interest to learn this procedure. I don't want people here to confuse. Physicians have experience with arterial lines and CVLs, but ultrasound-guided IVs, extended dwell PICCs, physicians had little to no experience with, but were really keen to build that skill set. The hands-on training and psychomotor skills were more highly sought than cognitive objectives. So we'll talk about the cognitive objectives of the curriculum shortly, but really the technical skills was what people wanted to get out of this curriculum the most. And then supervision had to be adapted to the level of competence, which means, yes, one-on-one supervisions at first for attempts, but a level of supervision that was going to grow with the physician's skills. And I think this quote here from one of the participants really sums up the results from the targeted needs assessment well. This participant was saying that they knew they felt the technique, how to put an ultrasound-guided IV or an extended well, but they hadn't had the opportunity to train and to do some attempts. And although they knew how to do it, really they felt direct supervision would be helpful to develop that skill set and build confidence. We determined that the curriculum would serve in achieving both cognitive and psychomotor learning outcomes. These learning outcomes were informed by Bloom's taxonomy. And so for the cognitive objectives, we expected learners to evaluate patients requiring specialized access and determine optimal site and device, which means, identifying when the patient needs an IV, an extended dwell, when we think VAT should put in a PICC, and also choose our sites accordingly, and not go at a site that might be used for a PICC line, for example. And I don't want to go into these details too much, but of course that was a very important part of the curriculum. And we then wanted learners to also understand and recognize complications of specialized vascular access. Psychomotor objectives were to demonstrate proficiency in the insertion of specialized vascular access devices, and we defined proficiency as a total of 10 ultrasound-guided devices for general proficiency and 5 extended dwell catheter for extended dwell proficiency. You may wonder how the number 10 was determined. It was in fact based on many studies showing improved proficiency around that number of success. The nuance here is that most of these studies are directed at nursing with landmarking and palpation IV experience, not as much physicians with ultrasound experience, but not as much peripheral vein experience. Still, with discussing with the different stakeholders, 10 was felt to be an acceptable number to aim for. There was no studies that we could find on extended wall insertion proficiency, but our thoughts was, since physicians already have experience with cell Dinger technique that is used for the extended walls here at CHEO, we thought that entering the vessel with a needle was going to be the most challenging piece, which is the same for PIVs and extended walls, whereas the rest of the technique with the wire and then cannulation of a longer catheter, ICU physicians are already familiar with that kind of procedure. And so in considerations of all these aspects, we determined that 5 extended wall catheters was a decent amount, plus 10 ultrasound guided IVs or extended walls to show proficiency in as per our curriculum criteria. To achieve the mentioned learning outcome, 2 main teaching strategies were developed. Firstly, a 3-hour didactic session was conducted in small groups, 1 to 3 people, to assess the address the cognitive objectives, but also practice on gel models and practice on each other if people were voluntary. Please note that these attempts, even if success, did not count towards the 10 magic number that we wanted to reach. We also created an infographic to facilitate explanation of the procedural skills. The infographic was showed both during the didactic session, but was available for fellows afterwards if they wanted to consult it. And then hands-on training was really the majority of the training. So direct supervision by a certified member of the curriculum. It was one-on-one supervision, which is currently almost exclusively done within PICU to facilitate workload and having learners both take care of the unit, but also be able to train in specialized vascular access. For assessment of learners, so the main assessment strategy was a dynamic assessment strategy, which is a continuous process. Once again, my goal here is not to give you guys a lecture on adult education and educational strategies, but what dynamic assessment means is that there's not a set amount of boxes to tick or questions to ask or a very like predetermined path towards learning. Dynamic assessment means that you discuss prior experience with your learner, figure out their strengths, their weaknesses, debrief after each attempt, and figure out what they want to work on and what you think as an educator they should work on, and then set objectives for next attempts. And so dynamic assessment is really great for adult learning because we are recognizing that learners come with a set of experience, with a certain expertise, and we meet them where they are and with them progress further into their learning. And so this has been the main ways through discussions, pre-briefs, post-briefs, really work towards improving skills. And then an EPIC database was also used to track progress. I've highlighted it here in the bottom of the slide. You don't have to go into details on that table, but basically the database allows us to track number of insertions, type of access inserted, tries, etc. And so to our training process, how we implemented this project. First, I myself trained under the vascular access team for many days and weeks, learning all the tips, learning all the secrets, aspiring to be as great as them. Can't say that I've reached that point, but definitely have reached a point where I developed proficiency in specialized vascular access. And then myself, I trained one of the PICU staffs first. And the reasoning for training the staffs, there were 2 reasons. One is to be able to have more people trained to supervise fellows, and 2, also ensure that this curriculum was going to have longevity. And so even if not all members that are trained in the curriculum stay at CHEO, at one point we'll have a core group of staffs that are trained and that can provide supervision to the fellows. And so currently we have 1 PICU staff that is fully certified, 1 fellow that is currently certified. And then our goal is to train all PICU fellows. So there's currently 3 PICU fellows. The other 2 are well on their way to becoming certified. And then we thought training 3 PICU staffs was a good point to start with in order to balance providing supervision to the fellows, but also training the whole staff group was not realist. And we did want to leave some of the attempts for the fellows, of course. And so it was important for us for PICU to have their own program because we recognize VAT is already a very busy mandate, and we don't think it was realistic to expect them to train all PICU fellows. And so we wanted PICU to have its own program. The next big step for our program is going to be conducting proper curriculum maintenance. A survey will be sent out in the upcoming week to all stakeholders that have interests in this curriculum and to learners to identify areas of growth. And for the upcoming year, so after this curriculum was implanted, quite a few parties in the hospital have expressed interests, notably PICU nursing and the transport team, allied health workers, have expressed interest in developing a similar skill set. Again, we have to be very mindful in how we train others we don't have currently the capacity to train 10 people at once. And so we really want to have a slow incremental approach. Another thing that I'm interested for the upcoming year is to explore PICC line insertion training for others than myself. I was lucky enough to have that team teach me insertion of PICC lines. And as we said earlier, during the first phases of the curriculum, we didn't think it was realistic to train everyone for PICC lines. I am curious for the next year to see if ever we are able to expand a tiny bit more towards PICC line. But again, this will have to go through thoughtful discussions, and there's a lot of considerations behind that. So we'll see where we get. And I know this talk had a lot of discussions that were very PICU specific for PICU patients and training. And I want to take this opportunity to end this presentation with lessons that are pertinent for everyone listening here from the Department of Pediatrics. One of the key challenges with curriculum development is the amount of work it represents. The multiple meetings we held and the slow incremental approach to implementation of this program may have seemed unnecessary. And part of me definitely felt that way at first. But looking back, it was really the only way to ensure a viable and successful launch of the program and to ensure to have buy-in from everyone involved. And so it does take a lot of effort to build a curriculum and to modify slightly how things work in a hospital, but it is well worth it for sure. Another big success of the curriculum was involving our adult learners into the process of curriculum building. This is a clear theme within adult learning that allows for learners to be empowered and feel like their voice is being heard. This then allows for better involvement of them during the learning activities because they feel like they had their say in it. Moreover, being a physician with formal medical education degree will serve me very well, and I would recommend it to physicians who want to be involved for program development here at CHEO. Finally, I think there are many opportunities for educational programs in a hospital, whether targeted learners are physicians, nurses, or other allied health members. And I hope this presentation served to provide both a theoretical framework and also practical information on how one may think about curriculum development to address their own educational needs. For myself, developing a curriculum has opened the door for many academic opportunities, and I'm sure colleagues would agree that when you work so much on a program, there are academic opportunities that arise. And very briefly, I'm hoping to use the EPIC database we have to show retrospective data on extended well catheter longevity. As I said, this data is absent in pediatrics. My ultimate goal would be to create a prospective database to look at other outcomes, such as rate of complications, possibility to do blood draws, longevity depending on different sites. So there's a thought that saphenous lines don't last as long as upper limb IVs, and that's definitely an experience I've seen, but there's no data on it. So to collect some would be interesting. And I'm also part of a Royal College National Committee on Point of Care Ultrasound, and we are developing a mandatory learning experience for Canadian PICU fellows. And so this is another field where ultrasound shines brightly within critical care. I hope this presentation was informative and interesting, and I'm very happy to answer any questions. And I would like to thank everyone for attending the presentation, and and listening, and I really much appreciate it.
Thanks, Olivier. It was very interesting and well done presentation as well. Thanks. I'll open it up to questions. I have a couple, but give the floor to someone else first if they want to ask. Donna.
Thanks. That was a really great presentation and great project. And this is kind of related, kind of not related. We've had challenges in the middle of the night getting cultures or IVs for oncology patients, like they spike a fever and there's no one that can do it. And it results in poor patient care. And so we go through the thing, but is there like a set, like people have to come to do it? It becomes a challenge. Like 2 weeks ago, anesthesia came, but then they got called away and they never came back, and PICU was too busy and NICU was too busy. So I'm just wondering your thoughts on the fact that sometimes we can't get IV access or blood cultures in the middle of the night, like how we can.
Yep. So thank you for this question, and that's a great topic, and certainly the middle of the night, even in PICU, is challenging at times because again, we really need the IV. Unfortunately, expert members of the hospital aren't necessarily available to put in that IV, and then we don't want to poke the patient 10 times. At the same time, we can't have an ICU patient without an IV, and those cases are really difficult. And so a couple of thoughts there. First of all, having fellows trained as a first phase, if they are available and willing, could help out in these instances. Another thought that I've had that we are trying to build towards is, again, teaching some of the PICU nurses how to do ultrasound IVs and improving their vascular access skills. I know overnights, PICU is very often asked on the wards on 4 North to help out with IV access. And if we can work towards improving their vascular access skills, the PICU nurses, then that is an opportunity. At the same time, with the current project we have, we can't be training 10, 15 people. And so we have to be mindful of who we train. And so likely the people who are most likely to be in these situations should probably be prioritized.
Thanks, Olivier. Dave.
Hi, Ollie. Another question would be, why not add resources to the VAT team so that we can cover 24/7 for non-urgent IVs, or potentially put a VAT person on call to come in and put a line in a situation where no one else can get there? That would take some pressure off the PICU and NICU and would result in better outcomes for patients like Donna's or for others.
Yep, great question. So two aspects to this question. First of all, I think for the training the ICU physician piece, because PICU fellows are expected by Royal College to develop specialized vascular access skills, and because other centers where these fellows might work do not necessarily have vascular access team, that's why we wanted to prioritize training of these individuals. Now, how does the hospital go from here in terms of a vascular access? Would it be better to have VAT help out more and have invest more resources there versus training some of ICUs? I'm not really in a position to make that comment, and to answer that, I'm happy to help out people. I see Sandra's hand is up. But for the program itself, we focused on fellows because it was the Royal College learning objectives, and it was about improving fellows' skills so that when they work elsewhere, they do come with some vascular access skills. I'll stop talking here, and I'm curious to see if Sandra, you had some comments as well.
Yes, so that thing came up quite a few times over my 16 years to have VAT coverage. And it's always like we did data collection, how much actually we are needed overnight. And there was never enough work to prompt us to be there. So it was always, it's been a couple of times, like during the years that we tried to collect data, but there was never enough to support having a staff overnight to do, to help out.
What about on call though, Sandra? If you got a call, you would come in and get paid 6 hours for a 4-hour visit.
I would not mind that. I don't have issue with, being on call. That will be great. But I know we went like, it's always a budget. So, but I would not have any issues on being on call and coming in. And
Great.
I'm
Maybe
sure-
we can chat about that offline, Sandra. Thanks.
Yeah, sounds good.
Yeah, thanks. And Sandra, I think that was your question, or your comment, or did you want to make another comment? I think that was the
No, that was it.
that was it. Okay. So Mark Zucker put a question in the chat. It was one of the questions I had as well, which was around maintenance of competence. So if you've gone through the formative experience and you've done the education, the training, the practice, how do you maintain competence? So Mark's question was, is there a target number of insertions required to maintain certification in access insertion? So how many people should be trained?
Yeah, exactly. Great question. So that's something we've chatted a lot about. Unfortunately, within literature, we did not find anything specifically on maintenance of competence. And that's something as well for fellows and ICU physicians for maintenance of competence for central lines, arterial lines. Data is lacking. What we've decided to do and what I encourage my trainees is that once they are certified, we encourage them to try every month to have at least one ultrasound guided IV or extended wall be inserted by them. And so that's kind of a criteria we've put together for maintenance of competence, not only supervise, but also keep inserting some IVs. I will be transparent that this is not validated with literature, but it was a number where we felt it would be realistic to start with. And over time, through curriculum reassessments, comfort zones of trained personnel, and success rate over time is going to be something to look at to ensure proper maintenance of skills. And you are absolutely right. It is something very important in curriculum building.
Yeah, thanks, Ollie. That was one of my other questions, was in terms of kind of evaluation of your curriculum, and it looks like you could get nice scholarly output from this as well in terms of a paper describing this, especially if you have an evaluative component. So my question was, how do you plan to evaluate this? Do you have any plans to write this out?
Yeah, the goal would be to publish this as a curriculum development project, for sure, and then program evaluation through a mixed method. So both quantitative data in terms of success rate, number of attempts, etc., but also qualitative data in terms of how other departments perceive the program, how learners perceive successes and challenges of the program. And so this is the planned approach to curriculum evaluation.
I had another question in the chat. Do you use sedation or anesthesia prior to inserting PICC lines?
For PICC lines, generally, yes. So at the minimum, of course, there's local analgesia that is usually going to be used. If it's a 16-year-old, very collaborative patient, not automatically there's going to be sedation. And then it's also going to depend on the ward, if the PICC line is inserted by VAT on the wards versus in PICU. In PICU, we are lucky to have access to closer monitoring. And so we might use mild sedation for both PICC lines and also sometimes extended dwells when we can, to lessen the pain, discomfort, burden of the patient and his family. And so obviously, for obvious reasons on the wards, it's not as easy, but sometimes patients can get an enteral Ativan or something, and then definitely always use local. And so, yes, or again, child life providing distraction is a great resource to have. And so that's other considerations to have.
Great. And while others are thinking if they have questions, I'll ask my other question as well, which is, I think the opportunity for residents and fellows to learn technical skills that they're going to need in independent practice, especially depending on the practice locations that they'll end up, as you pointed out in PICU. But if we go even broader, some of these technical skills will be required in a variety of practice settings. And the opportunity to learn and practice and get competence as well as maintain competence in those technical skills can be a challenge for residents and fellows. Do you think your experience here is generalizable to other technical skills that would be needed for people practicing in those kinds of areas?
I do think so. I think the process of building a program, evaluating needs, talking to different stakeholders is definitely applicable to different procedures. As you're highlighting, procedural skills is a touchy field within medicine, because we, in general, do less and less invasive procedures to the benefit of patients. Don't get me wrong, this is absolutely a positive outcome of the evolution of medicine. At the same time, this also means that maintenance of competency and maintenance of technical skills for physicians is affected. It would be great, like, and looking specifically at vascular access, general pediatricians in peripheral centers are being contacted to help out with IV access. And so currently this is not like, we don't have the workforce nor the amount of opportunity in terms of IVs at CHEO to train all pediatric residents. Now, is that something to consider in terms of, I think one of the very interesting things that this curriculum has brought as well is simulation training with gel models. And so although it's not perfect, it also serves to help out build competence. And so I do think if there is interest, there is something there, yes, but we are not currently at all at a state where it would be realistic for us to expand to pediatrics, but pediatrics could definitely take some of what we've done to inform future curriculum, if that makes sense.
Yeah, and I was also thinking of other skills like whether it's intubation or central venous line, whatever some of those other skills are. Could you generalize this approach? I could be answered that as well. Dare, I see you came on camera. Did you have a question?
Thanks, Ollie, for a great talk. I wanted to ask you if you had to pick one thing from each of two categories. So column A being what you see as the greatest opportunity now that you've sort of built this competency and this curriculum. And second, your biggest concern about being able to maintain it going forward. What would be greatest opportunity, greatest concern?
So I think the greatest opportunity here is to have healthcare workers become more familiar with the ultrasound machine, be more familiar with tracking a needle on the ultrasound machine and having it enter either a vessel, a pleural cavity, or like for procedures in general. And with the use of ultrasound, achieve higher competency and safer patient management. I think that's the greatest opportunity here. One of the greatest challenges is balancing opportunities to learn with not causing increased patient harms or discomfort, and also finding the time and the resources to, because like everybody's very busy at the hospital, everybody's very busy at CHEO. We are, on any given day, every unit is exploding and there's lots of discussions, lots of administrative work. And so to find the time to take aside a moment to train technical skills has definitely been challenging. And so that is one of the challenges of any curriculum building, and specifically this program.
Thanks. Does anyone else have any further questions? I think that's Ronish I see in the prepared conference room. Say hi. No further questions.
Maybe Ronish could comment on what they do down in Hamilton.
Not sure if they can hear us in the critical care conference room. Oh, looks like they can. Yeah. We were saying hi to Ronish that we could see on camera there, and Dare
I'm just trying to get him on stage here. Up on stage. Sing with the band.
Look, I got my certificate way before you. I've been doing this for years. I'm sorry, can you just repeat the question?
Yeah. Joke first, question second, answer question second, eh? I just was wondering if we have a couple minutes, if you could tell us how you guys approach this, either in the PICU or at the hospital down there for vascular access when things get tricky, extended dwells, ultrasound, guided, just state of the land in Hamilton.
Yeah, first of all, I would say that the CHEO vascular access team is like a top-notch service that we have a vascular access team, but they're nowhere as near as skilled and advanced in the equipment and PICC lines that use. So because of that, the rest of us are, we have to have a system where everybody else has to be able to put in, IVs, PICC lines, central lines, because we don't have a VAT team that can do that sort of thing. So we have a system where it is whether it's ICU team, fellows, sometime, and actually our interventional radiology service does a lot of difficult vascular access for us. So we also have a similar algorithm. I think that was being shown, but just the text in the boxes have different types of people in it that aren't VAT. So similar, but we have to spread out the vascular access skills because we don't have such an advanced VAT team. The T is team.
Great.
Thanks, Ronish. Maybe Ollie can get you a certificate, like an honorary certificate.
I'll look into it. There might be a mention honorary on it. Like, I want to be transparent here. But yes.
Great. And on that collegial note, maybe we'll call the rounds for today. So Ollie, thank you again. That was a very nice presentation and excellent discussion after as well. So thanks for leaving the time for that. Okay.
Thanks again for
See you
the
next week,
opportunity of
everyone.
having me. I really appreciate it. Thank you guys so much.
Great. Thanks.